Hello and welcome to the podcast series Unpacking. Today we are discussing diabetes stigma in the fifth episode of that series. This series is meant to help people be better informed and understand the nuances of a difficult topic and support their effort to participate in shared decision making. And we also hope that eventually these decisions will resonate with their priorities and improve their quality of life. PatientsEngage is a platform that empowers people living with chronic conditions and disabilities to engage better with their health and make informed decisions. And we advocate for more meaningful involvement of people living with long-term conditions in health system decision-making. I'm Aparna Mittal from PatientsEngage, and I look forward to this discussion today on diabetes stigma. Quick introduction, right? I mean, I think everybody's aware of diabetes. We know that people living with diabetes require daily self-care to stay healthy, to avoid or delay complications. And this burden can be exacerbated by stigma. We also know there's a constant pressure to meet specific number, the feeling of not doing enough, the feeling of inadequacy. The popular narratives where we emphasize success stories of diabetes remission don't help. They only add to the pressure that a person living with diabetes feels. And we don't take into account the social, environmental, and commercial determinants of health at all, right? So there's a lot that we have to unpack. We may not finish everything today's discussion, but we will make a start. And we also have to recognize that there is evidence that shows that diabetes stigma has multifaceted effects on people's health, their dignity, and well-being. And to discuss this today, we are meeting with an extremely interesting panel. Let me introduce the panel. The panel includes Sayli Jadhav, a therapist and dedicated qualitative researcher. She runs a queer affirmative trauma-informed therapy practice while exploring critical intersections in social science. Her research delves into the vital area of diabetes stigma. She lives with type 2 diabetes and offers a powerful, nuanced fusion of theoretical expertise and personal reality to the study. We've got Meet Shinde, an assistant professor in psychology at Srimati P.N. Doshi Women's College in Mumbai. He's a social psychologist by training and interested in weaving cross-cutting issues of class, caste, gender, and capitalism in his pedagogy and praxis. His current pursuit is exploring and theorizing experiences of stigma in healthcare. And we also have Dr. Chitra Selvan, Professor Endocrinology, MS Ramaiah Medical College, Bangalore, with more than 50 publications in national and international journals. And her areas of interest include women's health, PCOS, which we've covered actually in a separate webinar earlier, menopause, language matters, psychosocial aspects of chronic care. And we've got Dr. Tejal Lathia, DM Endocrinology, Apollo Hospitals, and the Hormone and Bone Center, Navi Mumbai. The areas of interest include, again, PCOS, obesity, menopause, osteoporosis, communication, and lived experience in chronic conditions. So we've got a fantastic panel, and I'm really looking forward to this discussion today to unpack the nuances of diabetes stigma, what it is, what are the consequences, and why it is important that we understand it and how this understanding can shape diabetes management. So let's begin. If Dr. Tejal, if you can introduce the study that you all have embarked upon and where the idea of this study germinated from, and why, from your perspective of running healthcare practices in diabetes management, do you think the study is important?
Thank you, Dr. Aparna. Thank you, Aparna, for doing this. Welcome, everybody. November 14th is World Diabetes Day, and every year we all do a scan and kind of get an idea as to the number of people who live with diabetes, and that number is ever expanding. The projections are geometrically progressing. We currently have close to 90 million people living with diabetes in India, and globally the number is 580 or so. And in the last few decades, the science of diabetes has progressed and advanced, and we've understood the science better. We've understood that if you're able to initiate glycemic control or attempts to bring sugars down as close to normal early, we might delay most of the complications related to diabetes. And in the last few decades of research, we've added a few handful of medications in the management of type 2 diabetes as well, including medications which could significantly alter your risk of renal disease or heart disease. And yet, if you do an audit of clinical practice, be it India or even the best of places globally, the mean HbA1c is about 8.9 to 9%, whereas the desired level of HbA1c, where your risk of consequences related to diabetes are almost same as a person without diabetes, is close to 6.5 to 7%. So in 2019, Tejal and I were attending the IDF conference in Busan, and we managed to converge into a hall which was holding a session which seemed like it was interesting, to say the least. So the topic was called Language Matters, and I walked in being curious, saying, what could language have to do with the science of, let's say, chronic care like diabetes? And this was a large diabetes conference. And we listened to an interesting session. For the first time, I listened to perspectives of people living with diabetes, along with experts taking care of people with diabetes. And it left me thinking about, is this a thing which happens only with the first world, or is this a thing which happens also back home? And it got me and Tejal in a reflective space. We got together to have a few words after that. And it was, the timing was perfect, because right after that, in about 2-3 months, lockdown struck, and we had all the time in the world to kind of, think about this. And we kind of planned a study, the preliminary study, to kind of understand the effect of language alone, because that was a breakthrough into this. And we did a study which had close to 30 participants who were invited from Teja's practice and my practice, because it was during lockdown. And we thought we were doing excellent as doctors, right? And then we had interviews of this, hours of interview. And during COVID lockdown, I would go on these walks and listen to each of these interviews for many, many minutes per day. And it was heartbreaking to listen to the experience of the person within the consultation room. And it's the same consultation room where I think I did excellent as a doctor. And the person who was sitting across me, their experience is so completely different from what I'm perceiving the whole interaction to be. So that got us into that whole mode of beginning to understand what language was doing, what the words we were using was doing, even to an extent what our body language was doing to people. But we realized that we were only scratching the surface, that all of that words and tone came from somewhere. It came from maybe the stigma which we have in our minds about people living with chronic conditions, especially a condition like diabetes, which is in some way believed to be that type 2 diabetes is a condition which is a lifestyle disease. So if you have type 2 diabetes, oh, you're doing everything wrong about lifestyle, as recognized by the world. So that required us to design another study to figure this aspect of it. Does stigma exist? Do people experience it in everyday practice? And I bumped into Sayli, and then that's how the group came together.
Excellent. So let's move to Sayli and Meet then. Can you define in kind of simple terms, and I hate using the word layman terms, but simple terms, what is diabetes stigma? And if you can talk through the types of stigma.
So I think even before we get into what is diabetes stigma, we could just talk about what stigma is, right? Because I think at this point we use that word, we use it as synonymous with discrimination or prejudice. But stigma is, in simple words, the experience of not being accepted. right? And the word itself comes from the idea of marking. So from sort of slavery to, even in cases of diseases where it will show up on your skin, and that's an indicator of, oh, I don't accept you, or that I need to stay away from you, right? And that, then how does diabetes come into stigma? Because we see stigma in cases of HIV or TB, because there's this idea of it being communicable. There's this idea of being morally wrong. But with diabetes, something very sort of strange happens, which is that it's not communicable, but that there is still this idea of you've done something wrong. Um, and yeah, so this was sort of an exploration of what that is about. I think Meet can talk about.
Right, right. So
Thanks,
Meet, you
Ali.
want to talk about? Yeah, go ahead.
Yeah. So, as Sayli said, that stigma often refers to an act of being marked, right? What is this marking about? Um, I think that to add to the idea of marking, it is important to understand that it is also an indicator of something being broken, right? It's an act of marking that something in some way is broken in an irreparable way. So, what are the various forms that this can take? Uh, Most often, the kind of stigma that we see playing in our lives is inherently in our social lives. So, this form of stigma that occupies public mindsets can be understood as public stigma, which often plays itself in important interpersonal relationships. That is one of the places where it appears the most, but that's not the only place where we see it. Sometimes you don't need an external actor to enact an act of stigma. Sometimes that stigma can also be something that you've internalized since your childhood, and hence it is a part, or it becomes a part of the way you see yourself or analyze or evaluate yourself. So it takes the form of what we would call self stigma. Besides self stigma, there is sometimes the manifestation of stigma in the structures, the social structures that we are a part of. These structures could be institutional mechanisms. These structures could these structures, as we are seeing in our study, is the way in which the medical world has internalized this stigma and enacts it in small different ways, where the person who is enacting the stigma may completely be oblivious to what their actions or where their actions are stemming from. Sometimes insurance agencies and the way they see people living with diabetes and what are the kind of provisions for them show us that there is stigma in those structures as well. So structural stigma is another way to understand stigma. And oftentimes when you talk to people, or when what we are seeing in our data is people who live with people living with diabetes or are closely associated to people living with diabetes, they are also at the receiving end of stigma from people who do not live with diabetes. So there is stigma by association, which we can call associative stigma. So yeah, roughly publicly present interpersonal stigma, self stigma, structural stigma, and associative stigma could be the various ways in which we understand stigma.
Right, right. And in your conversations with, as part of the study that you're doing, what are the commonly reported experiences of stigma? Sayli or Meet,
Sayli?
one of you is taking this.
Mm, I think that like the idea of blame of some form is one way in which this shows up. I think the idea that, oh, I think like Meet said also, right? The idea that you're broken now. So in sort of contexts where people are wanting to get married, it shows up in ways of, like somebody spoke about how it's almost as if this product is of lesser value than like another product which does not have diabetes, right? And so it's this imbalance of power. It's this moment of saying, hey, I'm better than you.
And I guess there is the inherent ableism, right? As because you said broken now, and there is that ableism of somebody kind of quote unquote whole versus broken. But so where do they feel the stigma from? What are the kind of sources? I know among your in your research, right? So you've talked of these 4 or 5 types of stigma, which is structural or social or interpersonal self. Where are, what are the common ones that you're seeing in your study and your research that you're doing?
Mm, I think it's so similar to sort of um, coming out in a way where everybody that you share this with, you don't know what reaction to expect. How they react is going to change over time. So it's not that, oh, somebody whose first response has been great is going to be like that consistently, and other way around also. So I think people at work, people in their immediate circle, which is, I mean, parents, yes, but then second degree relatives, friends, um, in cases of where they're seeking partnership, all of this, like everywhere. And in that sense, um, like all of these bits are existing in your life. And then the healthcare system is sort of where you go to for help. And then that's one more space where you're sort of facing this. And so, yeah, like I'm coming to you for help, but I get something that I didn't ask for in some way.
Right. And what are there phrases or, what kind of, I'm trying to make people understand where, kind of what defines stigma. So are there phrases that they hear that makes them, feel stigmatized, or are they, comments, words, how does it kind of play out for people? Or what do they remember? How do they internalize that?
So, what do they, or what are those instances, or what is the message that the participant in our study is hearing? If I may sum it up in, say, 2 or 3 quote unquote moral of the story ways, then it is that here on, I will be viewed as less than fully human because of something that I possess, and it is deeply embedded in me. So there's something about me which disqualifies me from full social acceptance or living a quote unquote normal life, a loss of normalcy as we see it. And in a certain sense, is a temporary slip beyond the bounds of social acceptability. So when I go to the doctor, and like Sayli said, one of our participants reported a doctor that almost immediately brought up, oh, you are 21 and diabetic. How are you now going to get married? How are you now going to find, or it's going to be so difficult for you to find a partner? Okay, for a doctor to say this has a certain impact onto the way in which a person who's trying to make sense of their condition is going to see themselves as. Or say, for example, a doctor telling the patient that the HbA1c report is indicative of a condition that is like a fully loaded gun that is about to shoot at them any moment. So think of this as a fully loaded gun, okay? And if you do not do X, Y, Z, then in a certain sense, you have drawn that onto you. So when there is this brokenness, as we call it, it doesn't stop there. It actually is the beginning point of who do you attribute that brokenness to, or where is this coming from, or who is this because of. And a lot of times it is seen as not stemming from the way our social worlds understand people of diverse forms and diversity in being and doing, but make it about the person and something within that person, rooted within the person and not in the social structure. So I think that these are a couple of small instances of what it could look like in the doctor's room.
Right, right. And I know that Sayli said stigma is different from discrimination and prejudice. So can either of you explain what that difference is? Because often people just use the phrase stigma and discrimination like almost as though it is synonymous, right? So
Yeah, yeah. Uh, so it's important to understand that both these concepts are highly connected to each other. They may appear uh, and sound similar, also may be used synonymously, but stigma and discrimination also have very clearly different territories that they occupy in terms of where they are played out and by whom. So we need to understand that discrimination uh, is the behavioral marker of prejudice which or stereotypes which may lie in the minds of the discriminator. So I understand somebody in a stereotypical manner, which makes me react to them in a prejudiced way, and that emotional reaction of prejudice shows up in my behavior as somebody who is discriminating. That's discrimination. It is important to understand that stigma, on the other hand, is the lived experience for that person who is not the discriminator, who is being discriminated, right? So, if we may say so, the discriminator, in a certain sense, occupies the actor position. He or she is acting, and on to whom that action is happening, the object of discrimination is the person from whose perspective we need to understand stigma. So the
Right.
subject position, the subjectivity of doing something, and the object position, I think stigma is what the world looks like if I'm in the object position, if I'm being done to or acted upon, and my agency to decide is taken away from me, or something's decided on behalf of me, or the act of being labeled by somebody as being broken.
Right. Right. And again, in your experience, and this is for all of y'all, what are the consequences of stigma that you are starting to see?
Heidi, would you want to take?
Yes, actually, this made me think about how, like, a lot of times when you go to the doctor and, like, the doctor is trying to tell you, hey, you have diabetes, but that it is communicated in a way where all that the patient understands is my life is over now, that this is what is going to happen. My kidneys are going to fail. I'm going to lose a few limbs. That I have to sort of, like, all of these amazing things that I used to love to eat, I cannot eat anymore. Or like if I'm eating, then I'm going to die.
Hmm.
Right. And so how do you feel when you walk out of that interaction? Do you feel like, oh, hey, I'm going to go home and like go on a walk? Or do you feel like, oh my God, like there's nothing I can do to change this?
Right.
I think that there are also certain very clear emotional reactions that an experience of stigma leads to. And the most prominent of them is an extreme form of distress, right? So
In
anybody
form
who is
of, sorry,
experiencing this
distress. Okay.
distress,
Distress.
anybody who is
Right.
experiencing stigma is also experiencing distress. What does
Right.
that distress do, or what are the emotional reactions that go alongside distress? Are emotions of sadness, emotions of anger, emotions of guilt. A lot of times stigma can make you feel guilty. It can make you feel exposed in a way that you might not want to be exposed, so it also leads to shame.
Right.
um, it's important to understand that a lot of times these things are happening at a point in time or in a space where you're trying to make sense of something that's not okay, that you are unable to control or unable to understand, which is for which you enter the doctor's cabin. The doctor asks you to do a certain number of tests, and you go back again trying to make sense of something. And in the moment of making sense, making meaning, what is handed out to you is a label, which is not enough for you to make sense of that condition. So when you are experiencing stigma, which is guilt, which is shame, which is anger, sometimes which is also fear, uh, your your moment of making sense of your life is greatly impacted by these emotions, and you walk out carrying this sense of guilt, shame, or fear, which in turn makes you not collaborate with the doctor, or which leaves you with a taste of unpleasantness. Yeah.
Hmm.
And there is a very simple law in psychology, which is called the law of effect, which basically says
Law of,
that
sorry,
if law of effect, law
law
of
of effect.
effect.
Right. Right.
Yeah. So it basically says that whatever action you do or whatever experience you have,
Hmm.
if that experience has a pleasurable or positive effect or a happy ending, then you end up redoing that thing. You end up repeating that behavior. At the same time, if you have a negative effect, which is an unpleasant emotion or painful consequence, then as a result of that pain, you do not end up doing it. So when I go to a doctor's clinic and it leaves me with a painful experience, which could be guilt, fear, shame, sadness, anguish,
Hmm.
I escape from it. I do not want to go back to it, or I want to avoid it. So that is one of the important repercussions of what happens when somebody is experiencing stigma.
Right, right. Dr. Tejal, you had your hand up.
Yeah, so just to add to what Meet said, what Chitra and I see all the time is disengagement from healthcare. So many times people don't go to see a doctor for 3 to 4 years. And unfortunately, what happens when even they do show up after 3 to 4 years, the doctor doesn't understand that it has taken a lot of courage for that person to show up after 3 to 4 years. And then again, the experience is negative that why didn't you show up for 3 to 4 years? So how this has changed the way I treat patients is now when somebody comes back, and after all the research we've done and what we've learned from our patients, is that when somebody comes back after 3 to 4 years, I take that extra few minutes to find out what was the experience they had 3 to 4 years ago, because of which they felt they could not go back to the doctor, in the hope that I will not repeat that experience for them and I will reassure them. So, one is disengagement from healthcare, is the main thing. The other thing that often happens is because of this negative experience, people will not take their medications, they will not do their exercise, they won't follow a healthy diet because so many times they're doing their best possible, but they're not judged on what they're doing right, but they're judged on the number. The HbA1c is 8.5%. So, what are you doing wrong? So, what the person feels is that if I've already done everything right and if still my numbers are not good and I am blamed for this, then I may as well not do anything. The third experience I've already often had is especially in people who have very long standing diabetes and they come across as very passive aggressive in the consultation. No matter what you suggest, they're like, no, I can't do this. I don't want to do this. And often in the past, I would misinterpret this as somebody who doesn't care about their diabetes, is not motivated, and is not a good patient, is how we categorize it in our head. But this is somebody whose journey has been so painful, like Meet was saying, that though they're there because probably a family member has forced them to be there, or they're having a problem which is so pressing that they need to show up, but yet they don't really want to be there, and they come off as being very passive aggressive. So those are usually the ways in which stigma shows up. And now, because of this research that we've been doing, Dr. Chitra and I have become sensitive to understanding the nuances. And when we see behavior which seems to be slightly different than what we expect, we immediately understand that something has not been right in the past, and at least we don't add to it. And we are very, very careful about how we negotiate or navigate this consultation.
Dr. Chitra?
Yes, I just want to come in to bring in a perspective. So I think traditionally, through our training, and our training predominantly is training medical students to look at the doctor-patient interaction as one in which you are sitting in the power of position of knowledge, and then you are telling others something about their condition. But I think the requirement of people who are walking into a consultation, at least in urban India, is that they are looking for a partnership which is more leveled and that is more collaborative, where you do not say the same 4 sentences to every person with type 2 diabetes who walks into the room, but you kind of get to know and understand what that person's specific concern might be, identify areas of improvement for that particular person, navigate through the challenges and everyday life, because diabetes has to be taken care of, but life also has to be taken care of along with it. And nobody's talking about all the labor that goes into it. Now, I know there might be some doctors in the audience who are thinking, oh, but what about my labor? I'm seeing so many patients. And yes, we acknowledge that doctors across the globe, and predominantly in low and middle income countries, are facing the brunt of the systemic problem which exists with the healthcare system in these countries, where the load seems to be all on individual doctors. But it's important for us to understand that that logic is not serving us anymore. While we are all busy, while we are all tired, burnt out, if we can just slow down a little bit to tackling maybe 2 to 3 small issues in one person's consult, and if that is going to alter that person's direction of movement or their relationship with self-care, with their chronic condition, we might eventually create a greater difference than what we are doing right now in our rushed, if I dare to say, unkind interactions on a day-to-day basis, with all of the constraints related to time, resources, and all of that put into place. Because diabetes is a chronic condition which requires engagement. It requires you to show up every day for yourself. And the way you are making peace with the condition and the diagnosis, and the Herculean amount of effort it takes to show up every day, even if it means to hitting your bedtime, even if it means thinking about your meal and planning your meal, or showing up for a walk, requires a lot of work. And I think the experience of all the conversations we have with people with diabetes, I think, is a call for them to kind of acknowledge that and to also kind of factor that in when we are writing our prescriptions. Because I think for now, as doctors taking care of people with diabetes, we are just saying take 2, 3, 4, 5, 6, and then meet me in 3 months with better numbers. Now this is on you, figure it out, right? And that's like the piece which is not solved for them. How do you navigate that space? I think that is the crux of the issue, that why we need to now reflect on the experience that that person had from that room after leaving. Like Sayli said, do you walk away feeling hopeful? Do you walk away feeling empowered? Like you can figure this out, I can come back and maybe get another set of tools, maybe next consult? Or are you left feeling saying, oh my God, I got blasted last time, I got blasted this time, I am going to then get blasted next time as well. So what's the point in showing up?
So two things, I think, before I come to your last point. So when I first started PatientsEngage, our idea was, building health literacy in patients, and I always talked of information asymmetry. Now I've realized that the information asymmetry is both ways, right? Because the doctors don't know what's happening in the lives of patients. We always think of information asymmetry, as you said, the doctor having the knowledge and the patients not having that knowledge. But as you look at the lived experiences of people, the information asymmetry actually is probably much worse off on the reverse, right? And the other thing, I think, on the systemic load, again, and from a patient engagement or a patient advocacy perspective, is that indirectly, that systemic load not just impacts the doctors, but it impacts their patients as well, right? So we're just not acknowledging that part of the impact of the load on, what is the quality of care that patients are getting as a result of it. And I think, to your point, yeah, I mean, on the supportive care, the care which is in partnership with the patient, I think that is something that we've always advocated for. And that's something that I think is across multiple conditions is still missing. We still are not seeing the patient as a partner, and how do we work towards helping them where they are, right? Because I think that's the point. They have their life to live. They've got challenges, and we see this in so many different examples. So we'll see that people who have retired now do better in diabetes management because they have more control over factors, right? You will see women who were caregivers to in-laws or parents, and then once that caregiving load reduces, they are able to do better. So, we just don't consider so many different aspects out there, and what is the level of control that somebody has on the factors out there. And this is not even starting to talk about the fact that when you tell people to make sure you take walks every day, where are the urban spaces for people to take walks, right? So and similarly on access to food, which is good quality as well as not, kind of harmful. So coming to, Sayli, or actually before that, Meet, I think just wanted to touch base with you before we get to the impact on diabetes management, because I think that's something that we will get into. But what do you see as the intersection with other factors in the experience of stigma? Be it age, be it gender, and this could be for either of you, or any other conditions like, say, obesity. How does that play out in terms of the intersection?
So, stigma does not often come in as a singular thing, right? Uh, if we were to give it an analogy, it is not a singularly standing tree. It's often a forest that comprises of many such trees, which grow together. So, what are these trees of stigma that grow together? One of them that we see going often hand in hand with stigma related to diabetes or diabetes stigma is medication related stigma. Right? It's stigma of having to now take medicine throughout your life. Again, connecting it back to the point of you being irreparably damaged, that you cannot now work normally if you were not to take this medication throughout your life, and stigma about that. Stigma related to weight, I think, is another important connected stigma that often goes hand in hand with diabetes stigma, of people not having done enough to be able to regulate the kind of body weight they have, the diet, the lifestyle that they're following, in connection with how we again frame diabetes as a lifestyle illness. Gender and stigma, we've seen, has played out differently in the lives of men, owing to the kind of expectations of performance, of being a provider, of being a protector, of being in control, which may play out differently for men living with diabetes, and therefore may have a different kind of impact on men. Will definitely show in the kind of sense of self that they start to have post the diagnosis, and women and the way the life of women changes with diabetes in their family or diabetes diagnosed for themselves, and the way they kind of take care of themselves with the other balls that they have to juggle, coming from the kind of gendered expectations that are there from women. So, like I said, it's not one tree, it's often a forest.
Right. And do you see a difference again in your study or even otherwise on in terms of age? Do you see a difference in the perception of or experience of stigma depending on whether the patient is young or older?
Sayli?
I feel like it's an excavation study and we've only like dug the first layer now. Because currently our study is of individuals that are young adults.
Right.
And I think as we dig further below, we're going to find a lot of more interesting things. Yeah.
May not actually be from doctors, but when people talk about their diagnosis of diabetes in their 20s to significant others in their life, to co-workers, to friends, to extended family, at that time, definitely there is a reaction of surprise, there's a reaction of shock, there's a reaction of extreme concern, almost anxiety in younger people that they report in moments of when they've talked about this to other people, which is also connected to another thing that people living with stigma can be seen doing often, which is hiding or concealing things that they can conceal about things that are seen as stigmatizing.
Right. And just on that, the study that you're doing is on type 2 or type 1?
Type 2
Oh,
diabetes.
Type 2. Okay. Right.
Do you want to share some more details about young people's experience of stigma, let us say, in social circles and maybe healthcare, which is unique?
That's to you, Sayli.
Sayli, yes.
Oh, I'm so sorry. I think that like a lot of people's immediate response is, oh, but you're so young. Like this idea of type 2 diabetes is an old person disease. I think that like I've even read literature where it says how like there was a time when it was associated with being wealthy, right? That, oh, you're wealthy and so this is what's happening. Of course, this is happening to everybody when you're old. but then when you're young, it's like but this isn't supposed to happen to you, right? That's when you're supposed to be doing great at work, like you're supposed to be running at the fastest speed you possibly can, right? And then it's like, oh, this thing is going to slow you down. So often it is also, it's like making a choice between, do I want to be like an adventurous, spontaneous young adult teenager, or do I want to go to 10, bed at 10 p.m. because that's going to regulate my blood sugars? And then how many spaces do I have to say no to? Are there spaces that are sort of accommodating for me to be in that space? Yeah, all of that.
Yes, Dr. Teja.
So, what we're learning from the study is already impacting the way that Dr. Chitra and I practice. And what I realized is, especially when we talked about young adults being diagnosed with diabetes, and when we realized that it's the diagnostic part, like why did they get diabetes, is something which is really painful for them and they get stuck there. And what I started doing in my clinic is, when I started explaining to the parents especially that there is something which is called as insulin resistance with insulin deficiency, and it's a combination kind of diabetes where lifestyle alone has not caused this. And the relief that you see on that young person's face, they feel liberated, because up until then, all they've been told by either doctors or everybody around me, oh, you sleep late and that's why you got diabetes. Oh, you use your mobile too much and that's why you got diabetes. Oh, you eat junk food and that's why you got your diabetes. Not realizing that every other kid that same age is also doing the same thing, but this particular person has got diabetes. So when we explain that, we see the tension de-escalating between the parent and child as well. The child or the young adult feels liberated that, okay, it's not my fault and maybe I can be a little kind to myself. And I
Right.
also feel that one thing that constantly comes up whenever we have conversations, and we had a conversation about this morning, when we are able to provide answers to what they are looking for or address problems that they are seeking help for, the trust that we build is an investment in a long-term relationship with that person and their family. So when Dr. Chitra was speaking, she said, I address 2, 3 small things, and the doctors are thinking, but I have so many things to address. But even if you address those 2, 3 small things, which is important to the person, they will come back. They
And
have
you can
trust that
continue
this
working on
person
the
will listen.
bigger issues.
And then the bigger
Or
issues
what you
happen.
perceive as doctors, the bigger issues.
The bigger issue, which may not be a bigger issue for the person at all. So I think at the core, when we recognize stigma, if we can reduce the perpetration of stigma in healthcare, we actually execute what we want, which is better health for our patients, which is what everyone becomes a doctor to do, but somehow it gets lost in translation.
If I can just come in to add to that bit, and I think we are having a large number of people living with the condition, or maybe who have a family member with it. If you take a look at the globe, close to 80% of people living with diabetes are in low and middle income countries, right? There is definitely something going on there, right? And it's important for us to kind of zoom out and kind of understand this big picture as well. So maybe in a simple way, if I could explain, traditionally Southeast Asia has been a land which relied on agriculture. So if you had a drought or a famine, you essentially lost hundreds and hundreds and thousands of people, washed out every year. So if this happened over hundreds of years, the only part of people who survived are people whose metabolism is kind of poised at converting whatever small amount of food you give into fat and store it and survive the next famine, right? So if that kind of selection has happened over many, many, many hundreds of generations, you end up with a population which is very good at storing fat. And then in the last, let's say 50 to 60 years, if you've exposed them to this sudden expansion of availability of energy-rich food, for the same amount of food, the people who are existing in this part of the world are very good at turning it into fat. And if you take a look at, let's say, body weight per se, we might not be weighing heavier than, let's say, the Caucasian world. but we tend to deposit fat in areas like the belly, which is more metabolically active. By metabolically active, what we mean is it makes us more insulin resistant. So you can have two people being the same BMI, and if you compare the fat stores in, let's say, the Caucasian or the white person with the brown person, which is us, you'll notice that we have a lot more fat and it's stored around the belly, and also deposited in our liver and in our pancreas. And it makes the pancreas struggle to produce insulin, and it also makes the insulin which is produced struggle to work at the level of the liver or the muscle. So it's like a double whammy which happens. And how were we supposed to imagine that there would be a day like this where there would be so much energy available that we will all be trying to lose weight, that we will all be trying to eat less? Evolutionarily, there was never going to be a situation like this. So I think we are completely discounting all of this when we are explaining the diagnosis or presenting the diagnosis of how this happened to you, to a young person. And I'm making an appeal to the doctors who've joined in to kind of think about this and maybe present it like that in the midst of the larger context. And also for people with diabetes, who've been diagnosed with diabetes, who have a family history of diabetes, to kind of understand this and kind of remove the blame that we might sometimes, place on ourselves as well.
From a real world example, right? How do you see, if you can kind of, we've talked of it from, I think we've given a lot of examples from the medical perspective, but if you can share a few examples of how stigma plays out in terms of impact on diabetes management from a lived experience perspective based on what you've been hearing, what you've seen around yourselves as well. So.
How it plays out is, I think, one, like the association of diabetes and food, right? So every time you're sharing a meal with somebody, either you conceal, which is that you sort of create this image of, oh, I'm normal, or that anything that you do that indicates not normal is going to start like questioning of some sort. And then it's about sort of where that conversation goes. Yeah. So oftentimes, like, it can be curiosity, which I think is like on the brighter side of what you could get. But otherwise, there is more questioning, there is judgment, there is a certain kind of like nosiness also in some way, like, when did this happen? How did this, like, things like that. Sometimes there is advice giving. Like, oh, have you tried to do this? Or I know this old uncle and like he had diabetes. People will also tell you things like, and then he like died. And I'm like, why are you telling me that, right? How is that helping this conversation? And that it's like everybody, you cannot predict when it can happen. There is no rules of, oh, you shouldn't be saying this, right? I think there is also this sort of assumption that you are bad at taking care of yourself. So I'm going to decide that. So then people telling you, oh, you should eat only one cookie from that box. Or like, are you sure you want to be eating that? Right? And this is people who don't live with the condition. This is people who don't know what it is like to live with the condition, but everybody thinks it's their business in some way.
And how does then that impact the person, right? So
I think so.
Yeah.
This is sort of interesting in terms of how there are so many ways or so many things you have to do to take care of yourself. But that every time you try to do something to take care of yourself, there is this response that comes with it. And so you're less and less motivated to do these actions. Yeah, I think that's like a direct, like everything is then a choice between do I take care of myself or do I assimilate in this situation to like go with it in some way?
Right. Yes,
Can I-
Dr. Jadhav.
can I
Yeah.
come in? So I think the identified theme for this year by the International Diabetes Federation is diabetes at the workspace. And I think I'm going to spend some time to address the challenges of that for young individuals in the workspace. I think close to 70% of people with diabetes are in the working age group, and they are not the retired population anymore. So they are now trying to fit into highly competitive, highly demanding roles at work with huge financial requirements that they need to fulfill for this path that they've taken up. So where disclosing that you have diabetes might is believed to in some way put you on the back seat. Maybe you will not get certain opportunities, or maybe you will be looked down as, let us say, not as efficient as the others in the workplace, or maybe you will be deemed as a person who's going to probably avail of more sick leaves and turn up absent at work. So that's one of the reasons why this information is usually not revealed at workspace, because the environment is not supportive, despite maybe the conversations or the lip service that we might be doing. What that essentially translates into is you're spending close to 8 to 10 hours at work every day. And now you can't be truthful or honest or open about your food choices. You need to have your snack, or you need to go in for a lunch break, or you need to take a medication before your lunch. And that's one important factor which does affect their long-term outcome. And when you are in that age group of the working age group, your body is able enough to kind of absorb the effects of diabetes itself. Like, let's say, for example, you might be having sugars in the range of 250 to 300, but you might be able to get through like a full day and not need to pause or stop or interrupt your daily life at all. And you spend those years just getting by without pausing to take care of diabetes. And what that will end at the end of the day translate into is, let's say, 10, 15 years down the road, even individuals as young as 35 and 40 end up with kidney disease or even heart disease. And we are all reading about how common that is becoming. So is it true that people are just dropping dead, or did they know about diabetes and did they not disclose it, or did they not feel comfortable to address it? Those are all the questions that we will have to reflect upon as a society, living in a world where say, oh, young men are just dropping dead in their offices. Like, clearly something must be wrong with just that person. So maybe we need to go back to our workplaces and then reflect on our reactions, our support, which we are providing to people who might have disclosed certain conditions, and how you can make places less toxic and more conducive for breaks, pauses, meals, water breaks, all of it, I think.
And I think I'd just like to add to that, when we talk of workplace, we kind of still think of an office setting, but a large part of our population is actually in informal work environments and, on the roads and things like that. So those have even less spaces for self-care for conditions like these, I think. So, Sayli, I think let's look at the way forward, right? We've analyzed the problem from various angles. We've looked at the lived experience. We looked at the physician perspective. You've given a few examples of how it is difficult it's a choice between managing diabetes versus being part of society, being accepted in a sense. How can various stakeholders be more supportive of people living with diabetes? And again, feel free to share a few examples so that it resonates with people and people like, they can relate to it more easily.
I think that's such a tricky question, because that every personal interaction that happens is so different. But like on the other end, when sort of you were asking this question, I had this idea of like a utopia almost, right? Of what does the world look like if I'm a diabetic person and I don't have to stress about having diabetes, right? Because right now,
For
like
that to happen, what would be the elements?
so I'll tell you my primary problem right now, okay? Which is that if I want to eat food, I have to either go really far or like spend a lot of money or think extremely hard because of how few options there are for what I could order that would, for me, be like, oh, this was an amazing meal, right? So every meal that I want to have, there's a compromise because honestly, like we have so many people that live with diabetes in India, but we're not designed for people that live with diabetes. So if I leave my house, 90% of what I get served is a carb heavy meal, right? So to me, like that food is available, that I'm able to be around people who aren't in their head thinking, oh, look, she's eating like another piece. That's why she has diabetes, right? Or they're not like looking at how many pieces of cake I'm eating, that they're not assuming that I'm bad at taking care of myself, right? That I can sort of sit at the table and nobody's going to look at my plate and think about any of this. I think like uh, to not look at me as like diabetes, right? To look at me as a person and that it's there in my life. I'm able to like figure out ways. I'm constantly looking at how can I take care of this. How do you like not make that more difficult for me?
Right, right. So assume competence, right? Assume that you know what you're doing. And from the, we talked to various stakeholders. So what would you expect from physicians?
I think definitely like the looking at me as a person. And I think that the first part of it also being important, which is like looking at me, not looking at my file, not looking at my report, not looking at my prescription, to look at me and talk to me, um, to see me as a person, and then also look at, like they said, what my problems are, where I need help from you. Um,
Right.
to acknowledge that, oh, I'm already doing like XYZ, right? Because oftentimes, even when you look at the prescription, there could be like 100 numbers, but you scroll to exactly like that number that you want to look at. And you're like, oh, you should do this also, and don't do this. And then this should be better. And not look at like those 99 numbers that you scroll to that were fine. To like ask me what am I doing, because and I think that as a therapist, like this is so important to me because you can't assume that, oh, I'm only functioning because of what you are telling me. I'm doing at least 50 things in the background that I have figured out how to do that work for me. Ask me about those and like, yeah.
Right, right. Meet, anything else that you would like to add before I kind of ask Dr. Chitra?
Always keep room for questions, I think, is such an important thing. A lot of stories that we are hearing from participants, one of the things that really makes them reconsider the decision of possibly going to the same doctor or not is the amount of room there is for questions, the amount of room there is for curiosity. Curiosity at both ends, right? What Sayli said, is the doctor really curious in me as a person? There's a very interesting quote in the Language Matters document itself, which actually says that this person does not know anything about me, but before I almost enter the clinic, the doctor is ready with a prescription about me or for me without
Right,
knowing me as a person at all.
right.
And a lot of our participants are saying things similar to that. They're saying that with X doctor, I have no room for any kind of questions. I almost feel like the doctor will get irritated if I ask him or her another question. Involvement is another thing. What are the ways in which I show involvement? I'm sure people may be involved, but how do I show that involvement? Something that Saili also said. There's somebody who says in the interview that the person sort of asking something, the doctor is responding to those questions. But while that response is happening, the doctor is constantly looking down and writing something. So the answering to the questions is happening, but she is not looking at the person at all. So these small things, that show the patient that I'm interested and genuinely so, that I empathize and I communicate that, and that there is room for curiosity, even if these small things are taken care of. I think usually the small things that have the most amount of impact. And that, from the beginning of this conversation, we've been saying that mere intention is not enough. That intention may not necessarily be the same thing as impact, and they could both be different.
Yeah, so I think there is a need for a follow-up to your language matters, which is body language matters as well.
Yeah.
So yeah, Dr. Chitra and Dr. Tejal, from your perspective, I know you've talked of how you've changed your practice, what you're trying to work on, but if you had to pick one thing that you had to unlearn, and also how do you see the doctor-patient relationship? How do you see that changing? How can you address people like Sayli and me telling that, I mean, apart from the room for questions, are you looking at them? Are you, what's the body language saying? Are they feeling heard? Are they feeling seen?
Alko Tejal?
Yeah, sure. Go ahead.
Okay. I think we are in the times of flux, right? I think we are all watching like a change in parenting style, at least in India. And I feel like the doctor-patient relationship is also in times of flux, which is similar to almost the parenting relationship, which is changing. So while millennials and Gen Zs are in their therapist's office talking about their experience as a child, I think it's kind of altered the way they parent. And now you are being more aware of what your children's needs might be, and that your job is only to maybe provide the safe space and provide the resources for them to fulfill their wishes and dreams, and not thrust your idea of what their life should be on them. And I think through the conversations that we are having with people who are living with these conditions, it is now obvious that it's the same mindset that you need to bring into your office as well. And your conversations also should follow that pattern. So at least for me, that's what I bring in to kind of understand what are your struggles, where do you want to focus today, what is the plan that you have in your mind, and then where would you like my inputs, right? And where are you thriving? So I think if you can equate it to the relationship or the way in which you talk to your children, you will kind of figure this out, and they don't need like a special training in communication. We've all figured out how to talk to our teenage kid. We know how we need to engage with them to get them into a conversation with us. You know that it's not going to work out if you spoke to them like your father told you, because I told you so, right? And because I know what's best for you, and we clearly know that that's not what we liked, and that's not what is going to work. So if you are listening as a doctor thinking, but I've not done this study, I've not listened to people's conversations, what do I take away from this conversation? It will be that to kind of draw them into the conversation, hold the space so that they stay and they feel like it's safe there with you, and that they feel like they can come back to this space to kind of get medical knowledge from you. And that medicine is scary, hospitals are scary, falling ill is the scariest thing on earth. I think we forget that as doctors usually, because you spend so much time there. And that everybody who walks into your room is shit scared, and they're faking the brave front. And it's important for us to understand that they're coming in feeling vulnerable. And then when you come down on them, and then when you expect them to leave the room after you've come down on them, feeling empowered and feeling like they've got this, that's just like beating a child and saying, do better next time. So I think that's something that all of us can very easily figure out if you look at that equation like that.
Peter?
Okay, I'm sorry, but I can't do only one, because I've learned a lot in this entire journey of the past 4 to 5 years. But in very short, I wanted to take off where me stopped, is intentions. So for the longest time, it was okay for a doctor to have good intentions and then execute the intentions any way they felt able, assuming that the intentions were just good enough. So the most important thing that I've had to unlearn is having good intentions alone is not enough. And I need to invest a lot of attention and care in how I execute my intentions. Constantly being aware that I'm in a position of power and it's not really a symmetrical relationship, and to constantly try to keep the balance of power, and understanding that every word I speak is something maybe this person will remember for the next 20 years. A very big change that has come in my practice, something that I've unlearned and relearned, is to start with what they're doing right, acknowledging what all the effort they're already putting into their diabetes, and then maybe talking about a few things that they may want to talk to you about and discuss. And that builds a lot of trust. Also, this is something very hard, which was hard for me as a doctor, and I'm sure it will be for most, to understand that we're a very small part of the person's diabetes journey, a very, very small part, and they're battling. I don't like, yeah, we don't want to use any war analogies, but the fact that there's a lot that they're struggling with outside of this clinic in their personal lives, financially, socially, psychologically, and I'm a very small part of this journey, which helps me to put into perspective of how I want to talk to them. And choosing a collaborative, non-judgmental approach, which does not stigmatize the people I treat, basically helps me to execute my intention, which is better health. So what doctors want is good health outcomes for their patients. And if communicating in a way which does not stigmatize them helps you achieve that outcome, then it's a win-win situation.
Thank you. I think we'll just do one final sentence to wrap up. Sayli, what would you tell a patient of diabetes? How can they deal with this? What is your message to them?
I think I'd have questions.
Mm.
I don't think I would want to tell them how they should do this.
Meet to the society at large, the people in their, not at large, but in their circle. What would you want them to reflect on and change? You're on mute.
Our ideas of how we understand normal and abnormal and what makes the norm, I think that if we were all to be true to ourselves and our lived experience, and not tell people the stories that we think people want to hear, but tell them what our true experiences have been with our life, with our vulnerabilities, with our strengths, with our weaknesses. The frameworks of normalcy will just crush and they will fall apart because everyone will have a life that's far away from that from the square of normalcy. It's not so watertight. It's not so clearly a mark.
One final sentence, Dr. Chitra.
To all the people living with diabetes, so when you walk into a doctor's clinic, I think you can look up reviews, you can look up patient stories. There are a lot of spaces where all of this information is exchanged, so you can find people who might understand you better. And if you do find them, pass on the message, because there are a lot of young people who are struggling with the challenges of navigating this space. And maybe begin to share the story of living with a chronic condition and not find the need to hide it as much. I think that also kind of adds to the stigma around it, where we do not want to speak about our own condition and our own struggles. And that's one way we can normalize that almost everybody is living with one chronic condition or the other, just that the person next to me doesn't know that, right? Yeah.
So maybe I would word it for the doctors, that the best evidence-based prescription in the world will be of no value if the person doesn't take it. And that is why it is so important for us that in spite of all scientific advances, the language that they use, the way we communicate, the approach that we have in the clinic ultimately decides whether or not this person is going to come back, whether or not they're going to take the medicines they give you, and ultimately whether you're able to fulfill your intention, which is better health.
And I'd extend that, when we say doctors in this conversation, it includes the allied professionals as well, nutritionists, dietitians, physical trainers, etc. So, because I think, especially in the case of diabetes, there's a lot of engagement with those professionals, and
Absolutely.
there are again the similar issues. So just thank you everyone for all of your comments, your conversations, your sharing of experiences. I think really what I took back from today's session is really that everybody needs to be kind, right, to themselves, to people around them, and to, as Sayli said, look at people, make sure they're seen, and seen and heard. And I think as for doctors or whatever, it's the room for questions, and obviously therefore it means that for the people, you can go prepared with questions. And I think the one thing that I think the other thing that came through for me is we constantly assume that when the number is wrong or the outcome is wrong, that the work has not happened. But that's something that you should not assume. You have to assume that there's been a lot of effort, but maybe the effort was not directed, maybe it did not have the consequences that you were hoping for, but there is effort. So never assume that there's been no effort. So you need to work harder at it to figure out how to reach the outcomes you want, but it cannot be a case of assuming that, and as everybody said, intention works both ways. So the intention is there. The work is also there, but we just need to make sure that it's executed right and, makes the right impact. So thank you, everyone. Thank you, Sayli. Thank you, Meet, Dr. Tejal and Dr. Chitra for yet another insightful conversation. And we hope, on the day after World Diabetes Day, that we have shed light on this topic of stigma in diabetes, and that will help people navigate their diabetes management, and it will help the professionals support their patients better. So thank you.